everybody. This is Dr. Britt Talley Daniel, MD, and I'm a neurologist and a headache doctor. Today I'm talking about migraine and estrogen. All right, so migraine occurs in 12% of the American population, and 25% of women and 6% of men have migraine headache. Migraine headache is the fifth most common cause of disability and the 10th most common cause of a visit to the emergency room. In medical school, they teach you the three most common known painful conditions that man has are migraine, a kidney stone, and childbirth. And I'm going to define a term here. Primary in medicine means that the exact root cause of medical problem is not understood. For instance, high blood pressure may be called primary hypertension, which is a very common medical problem, but the exact cause for it is not completely understood. In the same frame of mind, International Classification of Headache Disorders, version 3, ICDH-3, lists two types of primary headaches, and these are migraine and tension type headache. So it is said that 99% of all headache cases are either migraine, which is 30% of headache, or tension headache, which is 70% of headache. Tension type headache is the most frequent type of headache, but is rarely seen in the headache clinic. But migraine or supercharged migraine due to overtreating with painkillers called medication overuse headache, or a syndrome that may give someone what's called chronic migraine, is 89% of new patients in a headache clinic. So migraine is 30% of headache cases, and 60% of migraine ladies have menstrual headache, or migraine occurring in time related to the woman's menstrual cycle. ICDH-3 defines menstrual-related migraine as a migraine headache that occurs at the day of onset of menstrual bleeding, or 2 days before or 2 days after. So you got 5 days there. So migraine and estrogen. The migraine-estrogen relationship is likely why women have migraine 4 times more than men. The menstrual-timed headache is usually the worst, the most intense, longest-lasting headache a woman may have during a month. Medication with estrogen may be delivered through oral, transdermal, injectable, and vaginal formulation. And the transdermal delivery systems include patches, gels, sprays, and lotions, while vaginal products include suppositories, creams, and rings. All estrogen delivery methods may aggravate migraine headache, the intensity, the occurrence, and possibly reduce worrisome neurologic symptoms indicative of possible stroke risk. Some ladies who've always suffered pain with plain old migraine without aura may be converted to migraine with aura within a week or a couple of months of starting the pill, and they may then develop symptoms of visual images that they see, arm or facial numbness, or trouble talking. These women should stop their estrogen treatment immediately. Framingham data, which is reliable stroke data, has found that 6% of stroke for patients with migraine with aura have a stroke risk increased for women on the pill. All right. How does estrogen affect the brain to cause migraine? Although living, the late 19th century migraine savant and expert described catamenial menstrually related migraine in his famous book on Megrim, M-E-G-R-I-M, in 1873, it took another century and a half to determine that the human brain, both male and female, had estrogen receptors. In about 60 to 70% of women with menstrual migraine without aura, there's a strong occurrence of headache which come around the end of the 3rd week of the menstrual cycle, at the time when estrogen has been found to fall. There likely is a different gene sequence for menstrual migraine without aura. 30% of women with migraine without aura have no estrogen relationship at all. Exactly why falling estrogen levels trigger migraine is not clearly understood, but the relationship of falling estrogen as a trigger for migraine to occur is well known and factual. Welch et al., writing in 2006 in Neurologic Science on a title of Mismatch in How Estrogen Modulates Molecular and Neuronal Function, may explain menstrual migraine. They offer the hypothesis of a mismatch between the timing of estrogen effects on gene regulation in the central nervous system and its effects on cell membranes. Welch et al. Stated, quote, "On the basis of experimental studies and literature review, we propose that abnormalities in how estrogen modulates neuronal function in migraine are due to a mismatch between its gene regulation and membrane effects. In the interictal phase, when estrogen levels peak, increased neuronal excitability is balanced by homeostatic gene regulation in brain cortex and nociceptive systems. When levels fall at menses, mismatch in homeostatic gene regulation by estrogen unmasks non-nuclear mitogen-activated hyperexcitability of cell membranes, sensitizing neurons to triggers that activate migraine attacks. At the trough of estrogen levels, the downregulating effect on inflammatory genes is lost, and peptide-modulated central sensitization is increased, as is pain and disability of the migraine attack." Okay, estrogen production. What about that? The early to mid-follicular phases of the menstrual cycle are characterized by rising levels of estrogen produced by follicles in the ovary and under the influence of follicle-stimulating hormone, abbreviated FSH. Then luteinizing hormone, LH, causes the release of a follicle. Ovulation comes in 48 to 72 hours after that, with the luteal phase characterized by high levels of both estradiol and progesterone. If the ovum is not fertilized and implanted, the corpus luteum regresses, resulting in declining levels of estrogen and progesterone. The drop in estrogen in the late luteal phase is thought to be the key factor in the pathogenesis of menstrual migraine. What about estrogen withdrawal migraines? Somerville wrote extensively on the subject of estrogen withdrawal migraine and the influence of progesterone and estradiol in the early 1970s. Using quasi-experimental observations in a small number of women with menstrually related migraine without R, Somerville posited that the late luteal phase decline in estrogen levels could trigger migraine. He gave supplemental estrogen to women who reliably experienced migraine attacks at the time of the menstrual flow and found that the migraine was delayed until the supplement wore off. He also found that progesterone did not prevent menstrual migraine attacks. Well, are we sure about the migraine estrogen withdrawal theory? Leichten et al., writing in 1996 in Headache on the subject of the confirmation of a biochemical marker for women's hormonal migraine, the Depo-Estradiol Challenge Test, end quote, performed a study which supported estrogen withdrawal as a migraine trigger in postmenopausal women. These researchers gave an intramuscular injection of estradiol in menopausal subjects and then recorded the occurrence of subsequent migraines. Leichten et al. Studied 28 postmenopausal women volunteers made up of 16 women who have a history of severe cyclic menstrual-related migraine attacks before becoming menopausal, and 12 women, that was the control group, who had no history of migraine or headache. Results of the study were that, I quote, menopausal complaints of vasomotor symptoms were relieved for at least the first 2 weeks of the study. No member of the control group reported migraine during the month. However, severe migraine was reported by all 16 women with a history of migraine, and the average day of the migraine occurrence was 18.5 plus or minus 2.8 days. Leichten et al. Concluded. This study confirms two factors about menopausal hormonal migraine. One, it can be precipitated in a drop in serum estrogen levels. And two, a period of estrogen priming is a necessary prerequisite. The study also identifies that there are two biologically different populations of postmenopausal women. One, those who develop migraine after single depo-estradiol injection, and two, those who did not. By understanding that in addition to the biological predisposition to migraine, there exists the biochemical factor of falling estrogen levels, we may better understand this phenomenon and develop means to prevent its occurrence, end quote. Well, is estrogen withdrawal really what they call a migraine trigger? Loader et al., writing in 2007 in Headache on a title, Hormonal Management of Migraine Associated with Menses and the Menopause, a Clinical Review, stated, quote, cyclical ovarian sex steroid production may affect the clinical expression of migraine as demonstrated by a wide variety of clinical, epidemiologic, and basic science observations. Subsequently, multiple lines of evidence have confirmed the validity of estrogen withdrawal after periods of sustained high levels as a migraine trigger in premenstrual women. So there you got it, end quote. Do rising levels of estrogen protect against migraine occurrence? Well, McGregor et al., writing in the journal Neurology in 2006, studied, quote, the association between urinary hormonal levels and migraine with particular reference to rising and falling levels of estrogen across the menstrual cycle in women with menstrual and menstrually related migraine, end quote. They found a significantly higher number of migraine attacks during the late luteal/early follicular phase of the falling estrogen and lower number of attacks during the rising phases of estrogen. So there it is. McGregor et al. Stated, these findings confirm a relationship between migraine and changing levels of estrogen, supporting the hypothesis of perimenstrual but not post-ovulatory estrogen, quote-unquote, withdrawal migraine. In addition, rising levels of estrogen appear to offer some protection against migraine. Well, what about the worry of taking estrogen-based birth control pills or some kind of shot or suppository? Another common estrogen-related problem occurs when these women take a birth control pill which delivers estrogen for 3 weeks and then progesterone for another week, the typical pill, they call it. These women may find that taking the pill aggravates their migraine experience by increasing the number of headaches or by worsening the severity of headaches. Also, taking the pill may bring on migraine-R symptoms such as visual images, numbness or weakness on one side of the body, or trouble talking. Rarely, the pill may produce a stroke with permanent neurological deficit. All right, another question is, does migraine stop after menstruation stops? The old wives' tale is that migraine goes away after menstruation stops, but this doesn't happen in 30% of migraine without R women who have never had estrogen-related headaches. Their migraines aren't going to stop after menopause. However, estrogen-related women may have a pretty rocky time during the irregular pulse and varying amount of estrogen in their bodies, which makes perimenopause with their migraines, which were once least predictable, are now severe and irregular. What's the problem with exogenous estrogen? Exogenous given to a person in some fashion or another. Then sometimes to treat estrogen-lack symptoms, and those are real, they are vasomotor hot flashes, emotional nervous symptoms, vaginal dryness, and to delay the soft bone situation of osteoporosis, a gynecologist, internist, or general medical doctor may prescribe exogenous women, and this may help the estrogen-lack symptoms, such as vaginal dryness or hot flashes, but it may very well aggravate the occurrence and severity of their migraine experience. This analysis leads to the following dictum regarding estrogen and migraine. Circulating estrogen may aggravate migraine if it is pulsed or cycles, such as happens with the normal menstrual cycle with estrogen withdrawal, and elevated levels of estrogens may aggravate migraine. So this is my discussion today on migraine and estrogen. Please click on the subscribe down there so we can follow each other. I have a little more of the article, and the bibliography is on my website at www.drmigraine.com. God bless all you persons with migraine, particularly women that have menstrual migraine, and I'll see you again on another talk.